all of you are there online. I'm sure, can you all hear me? Can someone who's there online unmute and answer whether I can be heard very clearly?
Yes, sir.
Thank you. You are also heard very clearly. So we will keep this as interactive as possible. While the faculty will keep looking at the chat box, but it's a good idea if sometimes you unmute and answer so that the audience here also can record what you have answered. So we'll try and make a balance between interaction and still keeping it orderly and systematic. And once again, it's an earnest request to all of you that whenever there is a physical session, please come here and the learning will be better. Thank you. I think I hand over to Dr. Sikha Agarwal and Dr. Tushar Maniar for today's session. Thank you.
Thank you, Dr. Rajesh. Request Dr. Sikha to start, please.
Okay, good afternoon, everyone. And I would request the online participants, whosoever is possible, please switch on your videos if possible. Yeah. Nilesh. So we'll switch off this light. Don't worry. They cannot see the screen, so they are asking to switch off the light.
So actually, you need to only read the material. Just go on for 10 minutes and see what is this.
Okay, so I hope the online ones can see us, these slides as well. So we'll try to, in these 2 hours, try to cover the theory and the practical points that would be required to deal when a child comes to your OPD or in your exams, for that sake, with a limp. Okay, so going ahead, the first thing I want to say is history and examination is very, very important. It's not only just don't be focused on your exams, it's for your long run as well. That lot of mysteries can be solved with history and of course examination. So lab tests are 10%, especially in arthritis group and the limping group. First, you need to have a differential and then only you do the relevant tests accordingly. Okay, so what is the first thing when you go for any topic while you're writing the answer? The first thing that you need to write is name of the child. Theory. Huh? Heading, and then definition kya hai? So that is what. So anybody would like to take up the definition of limp, whatever comes to your mind. We are just small bunch of people here. So whatever comes to your mind. What does come to your mind when you think of limp? Perfect. Abnormal gait of a child. So abnormal gait. That can be what kind? It can be like jerky, take a support to walk. And what else would you like? So it's a abnormal gait, which can be jerky movements of the child, which can be, yes, perfect. It can be painful or not painful, antalgic or non-antalgic. So this is wonderful. So start has been very good. So definition, 4 points you will write. What is it defined as? It is defined as deviation from the normal gait pattern. Okay. It is uneven, jerky or laborious gait. Results because of these things, which is caused by either pain, and we know in a lot of neuromuscular problems, the child might not have pain, but weakness, which can cause limp, of course. So weakness, or for that sake, in a CP child, doesn't have pain, but there is a limp. So deformity. So caused by pain, weakness or deformity. And due to etiology can be hundreds. So due to variety of condition, 4 points defined as resulting in, caused by, due to. Gait.
Sorry, somebody wants to ask, what does doctor mean by age appropriate? Does a person walk differently at different age groups?
When they are toddlers, 50 years of age, 50 years of age, toddlers generally walk with 5 days out.
Very good, very good. So when does the mature adult gait come?
After 3 years or after 5 years.
Yes, so 7 years they say a complete mature adult gait comes. So I'm very happy at least the persons who are sitting here are very interactive, and this will force the rest of the online participants to come and sit in the hall in the next lecture. So what is normal? Normal is a smooth rhythmic process. Child starts walking, we know 12 to 15 months the child starts walking. 3 to 5 years, like you correctly mentioned initially, it improves. So till 3 years it is not that good, then 3 to 5 years is improved, and a mature adult gait is 7 years. 2 phases of gait.
Sorry, somebody, Dr. Aditi is saying I'm not audible on this mic. Am I audible now, Dr. Aditi?
No, sir, not so clear.
Okay. I think I'm pretty clear here. I can't make it better than this. She's saying not so clear. Okay. We'll work on it. Thank you.
My voice is clear, right, Dr. Aditi?
Yours is absolutely clear.
Good. So shall I go ahead? So you can use this. Okay. So where were we? The phases of a gait. Stance and swing. So stance is this when you press it and then swing it. So one leg ka stance and then one leg swings. Okay. Stance and swing phase.
So I'll try and show what Dr. Sikha is trying to project. Okay.
It's okay. So I think small thing. So stance to the support phase of one leg lasts for approximately 60% of the whole gait cycle. And then you swing it over 40%. Supposedly, if a child has a problem on this limb, the limp is a swelling. Here is a swelling in the knee. So what the child will do, all the phases will become small on this. And then he will try to bend all the weight on the opposite side, the normal side. Except when there is a problem with the girdle, the abductors. So in that sense, it will droop this side and the problematic side will have more of weight. Okay. So stance and swing phase. Remember, हम बोलते हैं दोनों पैरों पे खड़ा होना है, but एक पैर पे खड़ा होना ज्यादा जरूरी है. दोनों पैरों पे हम सिर्फ 20% of cycle पे खड़े होते हैं. एक पैर पे भी खड़ा होना आना चाहिए. Okay. So, yeah.
What happens when girdle is involved?
So we'll come ahead with that. So we'll deal with that again. So here we are just discussing the normal thing. Here we are just discussing the normal thing. So the normal is, you have to remember the stance and swing phase. Stance is 60%, swing is 40%, in which both leg stance is just 20%. Okay, rest you have heel strike, then this, and then toe, and then you swing on that leg. So stance and swing is very important for writing in the theory, of course, but when the child comes, you can understand how much is on that limb, which limb is affected only with the child walking in the room. Okay. So this is what is normal. So you would define it, then you tell what normal is. And what actually, why do you need to know all this about limping? So if you go by statistics, once you come out with as a pediatrician, I hope you will see at least 10 patients per day as a pediatrician. So every 2 months, you will see one child limping in your clinic. So it is approximately 2 per 1,000, and that is also a traumatic limp. Traumatic, so of course, it's much more. The child not had a fall or something and had a trauma and then limping. But it is approximately 1.8. So 2 to 3 months, one patient of limp, which you can deal yourself if you learn correctly. Okay. So that is what male is more, median age is 4.4, and it's equal both on the right and the left side. 80% is painful limp when it is a traumatic. So in the exams, this is not the scenario. This is the scenario, right? So you're not here, you're here. So you need to know the rest of the things as well. The causes, the symptoms, the investigations that you need to do in a child, and the treatment. So whenever you write a short note or a long question, you define it. You say the normal, then what are the causes of limp? What are the symptoms as per each cause, the investigations and the treatment that you need to give for that limping child. So we will deal with that one by one. So types. The types would be non-antalgic and antalgic. So of course, antalgic means pain. The non which does not cause pain would be first equinus. Anybody here who would take why? When is an equinus gait caused? Toe walking. Very common condition in neurology OPD. Yes. So CP, autism necessarily does not cause CP. If there is a tight tendon of Achilles, then they will walk on the toe. So equinus gait, or club foot is there, then there is an equinus gait. Perfect.
Why is it called equinus? Like a horse. Okay.
Then comes the Trendelenburg gait. This is what we were discussing. When there is a problem with the abductors, the problem is like when you stand on this, the hip of the abnormal side is not being able to take your weight and it droops on the abnormal side. So the stance on the abnormal side increases. It is not a painful gait usually. Trendelenburg gait. Then comes the circumduction. That is very simple. When you're walking, you circumduct and walk. You circumduct. So it happens with, yeah. And if there is a leg length discrepancy. So if this leg is longer, the affected leg is longer, then they will circumduct and try to keep the leg. And the last one is high steppage gait. So what, when there is a foot drop. Perfect. So very good. So when there is a foot drop, then you have like this, and then you will keep the like this high steppage gait. You will try to put your foot properly. So you will bend the knees more. So
What type of gait is there in Duchenne muscular dystrophy children? So how is waddling different from Trendelenburg gait?
Walking is because the proximal weakness is there, so alternative feet is like compensate for the weakness. Walk like a duck, the white.
Need battery change. Coffee. Okay. Can you all hear what they are answering? Otherwise, I'll have to hand over the mic to one of them as well.
So I thought Trendelenburg is when unilateral weakness is there. Trendelenburg is when there is unilateral weakness, and when the proximal muscle, and when there is bilateral, it will cause a waddling gait.
Excellent. Yeah. Very good.
So definition done. The types, painful, non-painful. Okay. Now we'll come to each etiological reasons. Okay. The
So-
causes of pain.
Yeah. Today we are discussing only limp. So this particular type of gait does not come under that. But if you are just to complete the discussion on gait, there's one more type of gait that you see, and that is called as ataxic gait as well as stamping gait, right? So when do you see stamping gait? Sensory abnormality. Very good. And why do you see stamping in sensory abnormality? Sensation and judgment. It's about the judgment about where the floor is. So they overcorrect and stamp on the way. Very good. Excellent. Thank you.
So coming to the causes. So causes are not always only articular or bone causes. There can be other causes also which can cause limp in a child. So first I've just included the intra-abdominal causes. For example, if there is a tumor inside and it's a big one, the child might limp. If there is a psoas abscess, then the child might limp. So psoas abscess is one of the causes where the intra-abdominal causes of limp.
Other ones, of course, the important one here in this today becomes intra-articular and bone causes. So when you write any theory question, for example, fever without focus or fever with focus, and when we start writing etiology, we usually divide it into headings: infection, hematological, rheumatological. Similarly, here also, when you are answering that, you can divide into headings. So one is congenital. There is a developmental dysplasia of the hip. There can be hematological, more importantly, hemophilia. So hemophilia can cause joint swelling eventually to a limb. Of course, very important ones are infection. So infection can be acute infections like septic arthritis, chronic infections with tuberculosis and Lyme's. And now post-COVID, you can include in all the list. One thing is post-COVID, the child can have a joint swelling, which can cause limb. Inflammatory causes, so that can be transient synovitis, acute rheumatic fever, juvenile idiopathic arthritis, okay, and some connective tissue disorder. I have included lupus as one of the causes here. So we dealt with intra-abdominal cause. Then we have the intra-articular cause divided into congenital, hematological, infection, inflammation. At least one also, if you know the important ones, that helps to complete the list. Then the bones, again, congenital, like you have a club foot, like we discussed. So club foot, then developmental, that is Perthes disease, capital femur crisis. Then you have infection, osteomyelitis. So there we had septic arthritis. And then you have the neoplastic conditions. So it can be benign, which can osteoid osteoma, malignant like leukemia. Okay, so these three categories I have included. There can be other, like I mentioned. So there can be neuromuscular, so muscular dystrophy, cerebral palsies, which can cause limb. Soft tissue, important. Any cellulitis, if there is a lower limb cellulitis or local soft tissue inflammation, then that can cause a limb. So you include intra-abdominal, intra-articular, bone, neuromuscular, soft tissue. In each heading, you try to give examples. In intra-articular and bone, you divide them into congenital, infection, inflammation, hematological, and try to answer that. If you know that, even in practical, that helps you, because then you can form the differential diagnosis when you're dealing with a child. Okay. So causes done. So this can also be divided according to the age of the child, but then let's skip that because we have already dealt in details with the rest of the things. Okay. So coming to the evaluation of a child when you see a child with a limb.
So in the exams, theory can be questioned on causes, can be asked as different things could be give causes of child with limp. It could be a more specific question saying give causes of a 4-year-old with limp. So then you will have to filter 4. When they say 4 means you will take from 2 to 5 years of age, correct? Now, if they ask you enumerate causes, then you can enumerate the causes either in the form that Dr. Sikha has just now mentioned, but always when you are writing answer on causes, you can put something like an introduction, which will come on the top, which will say, for example, the life-threatening causes of limp can be, okay, or treatable causes of limp can be, and you can give 3 or 4 causes there, and then you can go in a formal way of giving a differential diagnosis, which is concept based for that particular subject. Okay, thank you.
Moving ahead, now we will start with the kind of practical part, which also you need to write in theory as well. So practical part when you deal with a child with a limb. Okay, so first thing, of course, you ask the name, gender of the child, the locality from where this child has come, and then the chief complaints. So chief complaint, of course, here is pain or a painful limb. So anytime when you ask this history, we go by old cards. So what is the full form of old card? Anybody? Or any other mnemonic which you all use? OPD. OPD. So this is more elaborate. Onset, location, duration, characteristic, associated or aggravating factors, relieving factors, and treatment, if any. So that will help you to complete the whole list. Okay, onset, the location, in the sense that if they are limping, whether it is a knee paining or ankle paining or the hip paining, then the duration, of course, acute hai, chronic hai, that will help you decipher that. The characteristic, if the child or the mother can say, especially I have mentioned 3 things: morning, evening, night, because when the child has a painful limb, this history becomes very important. Again, now you haven't answered anything, huh? Something, anything. When will the child have more morning pain? Rheumatoid diseases. Inflammatory. Very good, very nice. So inflammatory diseases, the child will have more morning pain. When will the child have more night pain? Malignancies. Perfect. So malignancies like leukemia or even osteoma, the child will tend to have more night pains. Okay, and evening is usually mechanical. For example, growing pain hai, but then usually that doesn't cause a limp, but agar mechanical hai, so that can be evening pain. Or fracture hai, aisa kuch reasons hai, so it can be anytime. Okay, continuous. So morning, evening, night, when you are taking a history and presenting a long case on a joint swelling or a limp, that becomes an important part that gives you extra marks. Okay, trauma you have to ask, but remember, माँ को पूछा बच्चा गिरा था क्या, हाँ ही होता है उसका आंसर. So you have to decipher, बेड के ऊपर से गिरा था, कितने ऊपर से गिरा था, आपके सामने गिरा था, विटनेस था या नहीं था trauma.
So when you talk about history of trauma, whether you're writing for theory or for practical, apart from taking very detailed history about trauma, but remember for trauma, you are thinking about usually an acute trauma. Also keep in mind conditions of repetitive trauma and think about non-accidental injury. When you talk about non-accidental injury, think about pathological trauma. Absolutely. So trauma may sometimes be an effect of an illness, of another event like a seizure with the trauma, but it can also be that a minor trauma brought attention of the parent to that swelling or to the joint. Okay, so you have to just make sure in your detail, when in your history, all the details that you are dealing with, either the trauma is responsible for this or not, and the effect of the trauma is proportionate to the trauma that has been mentioned to you. Okay, it's important for case also, and when you write your exams or when you write approach to a child with limp, you can differentiate on these bases.
Okay, and of course the systemic symptoms. So associated with limp, if there is any fever, there is any rash, there is any preceding factor following which the limp has started. Come to the examination. So history has been pretty short pertaining to the limp. Do you want to add anything?
No, so I was just saying that for limp, what is your algorithm? What do you think about when you, if you were to write an answer on approach to limp, what would you write?
लिम्पिंग है तो कौन सी साइड पे नॉर्मल abnormal.
Okay.
Yes, please go ahead, Amaya.
हेलो, हाँ बोलो.
Music is welcome, but we would like to hear you as well.
हाँ.
Amaya, can you if you are not answering?
Post mute.
Rajiv, you want to answer? Rajiv Srivastava.
Yeah, we can go by this, whether it is painful or painless.
अरे
And
उसको एनबीए में ले लेना. लक्ष्यता यार उसको बताना.
yeah, hello. Yeah, first we have to make sure whether the limp is painful or painless, and according to the age and sex, we have to think about the cause in that particular is whether it is inflammatory, infection, trauma, tumor, or something like that. Then we can go ahead along with the associated symptoms and signs and onset, duration, aggravating and relieving. Accordingly, we have to distinguish between the different causes. And finally, we have to investigate later on with the imaging or blood investigation to come at one diagnosis.
Excellent. Excellent, Dr. Rajiv. Thank you. So just to give another angle or what I would be thinking, which would be applicable not just for limp, but for other things. So think about the first bifurcation. Suppose you are talking about heart disease, you are thinking about congenital and acquired, right? And then you are thinking about cyanotic and acyanotic, obstructive and non-obstructive, so on. So same way, now limp, you are starting with what? You already said, right? Painful and painless, correct?
Single joint or multiple joint?
Okay, so there are multiple ways in which you can approach this. You can go age-wise, you can go etiology-wise, you can go by monoarthritis, polyarthritis, by the pattern of distribution that Dr. Sikha will explain to you and give you examples of the same. If you're thinking about painful, what are the things that you want to think about first?
Just arthritis.
Pain is equal to trauma, right? First, or fever or inflammation. So if you say inflammation means either with fever inflammation or inflammatory conditions, but no fever. So painful divided into with fever, with trauma, or with no fever and no trauma. Okay. See, everybody will have their own way of writing things. Okay. So I'm just giving you an example. Now, if you say with fever, what is the thing that you generally ask for fever? How do you differentiate various causes of fever apart from etiology? Duration, correct? Excellent. So you think about acute conditions of fever. Then you talk about, say, few days of fever, more than 1 week of fever, and prolonged fever. And then you will automatically get, you already have a pain, you have limp, and you have fever, and a fever of different duration. So you have at least few causes of that, right? We will not get into that because then we'll just be talking only about it. So think about trauma. So what I told you just now, trauma means you're thinking about acute trauma. Now, if you think about acute trauma in the answer, when you're writing a theory answer, you start from whatever can cause limp. So don't say upper limb trauma will cause limp, right? So the spine se start karke, it can be spine, it can be hip, it can be knee, it can be foot or ankle, right? So you can have various things which can give rise to limp. Repetitive trauma. No, even stress fractures, or what I was talking about is something like Osgood-Schlatter, where you have repetitive injuries, right? And the third one, what we said, non-accidental injuries, right? So that you can put what are responsible for non-accidental injuries. You go on to no fever, no pain. I mean, no painful, but no fever or no trauma, means no history of trauma or no history of fever. So then you think about condition which will have minimal fever or can present with pain, but no fever. So again, if you think about it, your slipped capital femoral epiphysis, Perthes usually is not painful, but can be having mild pain, as she said. So you can start with that point. Then you can answer a few more things over there.
So Perthes are not painful.
No, so again, Perthes are typically not painful, but early on, or some patients can have mild pain. So it goes in both sides. See, one simple thing you remember, for writing a theory answer, use a wide angle lens. Cover as much as you can. Okay. And when you are answering in the exam, you use a telephoto lens. So you focus and give answers specific to the patient who is standing in front of you. When you talk about non-painful limp, you talk about, classically you think about is neurology, right? First thing that comes to, see, I'm not giving you an answer. I'm trying to make you think about how you will answer. So first thing you will think about is neurological. Second, no, rheumatological, not painful, difficult. No? This is not painful. It could be structural, right? Like a limb length discrepancy. Okay. Or it could be functional, right? And in neurology, suppose you have to divide further, how will you divide? Correct, correct, absolutely. Or you go by the neurological features, whether there is spasticity, whether there is a muscular weakness, whether there is hypotonia, hypertonia, lack of power, lack of balance, etc. Whichever way you go. So you just think about what you have differentials and go accordingly. Thank you, doctor.
So
different perspectives sir has given, and that's really good that you can take all these things in your history as well when you're, it will help you differentiate the way sir has told. Okay. Coming to the next thing, you will directly go ahead with evaluation of the child. So same thing, inspection, palpation, that's what we do in the rest of the systems. So we see the child from all sides, we see the gait pattern. So here is one slide which I included for inspection. So you can see the limb here.
One of you, just pick up the mic and describe what you see. Say this is a 10-month-old, not 10-month-old, sorry, we're talking about limp, right? So 15-month-old. No, not required to be clear.
The other ones will not be able to see. So that's the reason they have not switched off.
So the left lower limb is flexed at the knee joint and looks short as compared to the right lower limb.
So let somebody else please go ahead.
Yeah. Now you can see.
Is better?
Now right is extended and left is flexed. There might be some either normal or some extension towards the right.
There is a abduction at hip joint with flexion at knee joint
Very good.
and rotated.
Perfect. So hip is externally rotated. So external rotation of the hip is a position to maximize the intracapsular joint space.
Remember, this is a very important concept. Everybody on chat, Dr. Sikha, please can you repeat for them? The
So,
concept of intracapsular or I would have said intra-articular, but she's absolutely accurate to say
So
intracapsular.
basically, intra-articular joint space of the hip, if you have a fluid there, then the child tends to externally rotate the hip, keep the hip externally rotated with knee in the flexed position, so that the maximal space can be attained intracapsular or intra-articular. So here, if just by the picture we want to identify, if you can see this is normal, keeping it straight, but here this is like you all correctly said, this is flexed and externally rotated so that the joint can have maximum space here. So if just by seeing the picture, if somebody tells you which joint, so this would be the joint. The position says us that this might be the joint that is involved. So that's what. There is a flexion, I think we should have been here, flexion and external rotation of the hip. Okay. Good. So here again, the same thing. You can see the flexion and external rotation of the hip. Sometimes, of course, in knee joint swelling, also the child might prefer this kind of a position where there is a flexion of the knee joint. This one. Yeah, so this is another thing that you can maneuver the child to keep both the foot together, and you can see this is not going outside more. This is going properly outside. So here there might be a restriction here. With chronic disease, there might be some restriction of that joint movement if the child is not being able to externally rotate that joint completely normally. Okay. This one, I think this you all know better. Anybody want to take it?
Limb length for limb length
Yes, so
discrepancy.
this is a specific test name that's called. So you ask them to flex and you can see there is a limb length discrepancy. That's called the. Yes, perfect. Nice, very nice. So
When do you see that particular sign? DDH.
DDH.
When can you miss if you use only Gallagher's sign and you will miss DDH? In which situation? Bilateral, excellent. So this picks up asymmetry. You're very right, it is used for DDH. But if it is bilateral DDH and of course equal, etc., etc. Correct.
okay, so very interactive. I just online participants as well. If they have anything, please interact and please switch on your videos if you can.
And at least write on the chat box, I'm monitoring, I see an answer of DDH. And today it's voice of Tushar Maniar with face of Dr. Rajesh Chokhani. So don't worry about that.
Okay. Yeah. So the next would be if you see any swelling or anything is there, so we'll do with the patient as well. So you see what kind of a mass is there, the tenderness, the adjacent joints, the range of motion, and the additional tests. The additional tests why I mentioned here are 2-3 things. One, we have already mentioned the Galilee. The other one where you try to see the position and you try to join both the foots of the child and try to see how much the external rotation of the hip happens. The second, like I discussed, that to keep maximum space in the joint, there is external rotation of the hip. Similarly, if you flex the knee and internally rotate the hip, okay, then sacroiliac joint gets stretched and there can be pain. So flexion, will do it with the patient, flexion and internal rotation of the hip. So internal rotation of the hip, I'm so sorry, internal rotation of the hip would be for the hip pathology where there is minimal fluid. External rotation of the hip, if there is a SI joint pain, the child will have pain.
So all these tests what doctor is describing come under what are called as provocative tests. And provocative tests are used when there is a minimal affection of the joint or you want to stress or put stress on a given joint.
Okay, we'll do with the patient. And what we will do with the patient is a P-GALS examination. Okay, so this I think we'll do it later. Anybody would like to do the definition here with the online participants? Can anybody tell us the definition of limb? Like if you write in the theory. We have already discussed the definition of limb. No, online participants. Anybody in the online participants? Define.
Any deviation from the normal age pattern gait.
Okay, defined as resulting in.
Abnormal gait.
So defined as an abnormal gait, okay, resulting in jerky or laborious movement, which can be caused by
pain and weakness.
Yeah, very good. So pain or weakness or deformity and can be due to varied conditions. So here we finish the definition of limb. So this is Dr. Rajiv again answering, right? Yeah, so please, other doctors as well, Dr. Nikhil, good that you have switched on your video, so you can also answer if there is. Okay, now we come to the. So this is kya baat hai? Okay, P-GALS. So P-GALS, what is P-GALS? Nikhil, can you answer what is just the full form of P-GALS? Very easy, simplest question.
Rest of you can write on the chat box at least.
It is a pediatric assessment of gait, arms, legs, and spine.
Okay. So P-GALS. And of course, now by this time, we have seen how we are going about limbs. So we know, okay, why do we need to know about this? When and on whom to perform. So P-GALS is basically with the rapport formation with the child. So if you say 2 years child or 3 years child, it might be very difficult. So they say above 4 years or 5 years, you can always perform the P-GALS. It's just a 2 minutes examination and you should have a good rapport with the child. You should do the maneuvers yourself so that the child copies with you and it becomes easier for you to do the P-GALS examination. Okay. Variance in gait patterns and things we have studied, normal motors milestones. So basically here I wanted to include that there can be toe walking, can be normal till 3 years of age. Bow legs can be normal till 18 months of age. That I am sure it's more of theory which you can go and read. Components we've discussed, so gait, arm, leg, spine. And as we do the P-GALS, we will see how does it differ, certain things which differ from the adults. Okay, so one by one, we will try to cover the first thing.
So one important point is P-GALS is a screening test. So you have to remember, just like all other screening tests, the sensitivity is high, specificity may not be high. So you are only, what you are trying to do is pick up a possibly affected joint in a short period of time. And then you will do a detailed examination of whatever the suspect area is.
Okay. So for P-GALS, the first thing is observation of the child. So we observe, we actually uncover as much as possible, observe from front, from side and from back. Okay. Then we come to the gait of the child. Okay. So gait is first we ask the child to walk normally. Okay. Walk up and yes, walk normally. So walk normally, we know that if it is affected, then the side will be, the stance will reduce on that side. Okay. Then we ask the child to walk on the toes and walk on the heels. So this covers the whole lower limb, smaller joints and the ankle. Heel helps in one more thing is flat foot. So a lot of times we diagnose as flat foot, but on the heel, if the arches are formed properly, then the child doesn't have a flat foot, because the labeling of flat foot is very common. You should not always label flat foot. Okay, so if the arches, you see yourself when you do this, your arches will be better formed. So in that, the arches are formed, then it's not a flat foot. So observe, then gait. Simple three things: walk up and down, then on toes and on the heels, ankle and smaller joints done. Then we ask the child to lie down and examine the knee and the hip. Okay, hip we have already discussed. So normally, if to maximize the space, the external rotation happens. But if there is minimal fluid, we do internal rotation of the hip to see whether there is minimal fluid inside or not. So we flex the knee and we internally rotate the hip to see if there is a hip pathology or not. Knee, one is flexion extension we are already doing. For examination of fluid, we push from here down and we see the patella movement. So if there is a fluid inside, it will be feeling like inside a cyst. Or we can do a patellar tap to see the fluid. Okay, so simple. The lower limbs are done. We will so arms we have to do the arms as well. So arms was anybody wants to take up? Yes. Okay.
And other thing the child will do is the thumb, this way, fist, then you can take this. Then then first they will touch this thing, thumb and touch the finger. Then they will fastly touch all the fingers to see the movement of small metacarpophalangeal, right? Namaste and the pause.
Yeah. So holding hands straight, holding hands opposite side, and then this one, the metacarpophalangeal. From metacarpophalangeal. This one. So nakaliya, yeah. These are the intercalaria. So metacarpophalangeal joints. Yes. Okay. Here only, correct? This is good. So what we did till now, I'll just show with the arms. So first is you stretch your arms. Okay. Fist it. So stretch like this, fist it. Again open it and then see this. So this is manual dexterity as well. So with neurological things also it will help. Then you press the metacarpophalangeal. You press the metacarpophalangeals. Okay. Then you fold the hands. Okay. And then very carefully, not like this. Huh? A lot of times the patient will do this, but you'll have to ask do this, then ulta, then hands go up. Okay. And this. This one and this one also comes. This also comes. Okay, so this completes. So this not only completes this, overhead movement of the shoulders are complete, the neck movement, cervical is complete. Okay, later that will be back spine. So this is how we cover the arms. Okay, the arms, legs, and then last becomes the spine. I'll just show you first. This is fisting. Metacarpophalangeal joint, to be very careful here. This we did, this we did, this we did. Okay. Then came the leg. This we have already done. They are internally rotating the hip to see the pathology in the hip. Okay. And then comes the spine. So spine, like you said, we have already done. Cervical we have seen with this. We asked this movements as well. And then we ask them to fold and bend down without folding the knees. So we can see the dorsolumbar spine. Okay, the dorsolumbar spine. And one thing which we do is, one more thing left is, yes, 3 fingers.
Yeah.
So TM joint. So TM joint and the toe walking, heel walking are not there for the adults. This is only for the pediatric one. So that is the reason pediatric gait arm leg spine. Okay. Anybody in the online who want to ask, what do we ask? We ask, what is PGAL? They have already answered.
What are the
When-
3 questions before we start examining for PGALs? Somebody can write on the chat, please.
3 questions.
First question we can ask that do the child have any pain or stiffness in the joint muscles or the back? And second question, do the child have any difficulty getting oneself dressed up without any help? And the third, is the child able to any difficulties there in going upstairs and downstairs?
Okay, so again, the favorite alphabet of the ABCD is Y, right? So why do you ask the first question? You know the child has pain, that's why you're maybe doing the PGALs, correct? At some point in time. So why do you want to know if the child has pain anywhere?
Only for the cervical, because we don't want, like, we want to avoid the cervical pain.
Okay.
So that it will cause.
Okay. Explain. Basically, we ask so that always, whenever you examine any patient, you always go from non-painful area to painful area and do your non-threatening examination first and threatening examination later. Also, if you know that this part is paining, that particular PGAL maneuver, you may not even do, because the idea of PGALs is to do a screening test. Okay, I'm not telling you to skip anything in your exams, but I'm telling you in a real life scenario, somebody comes with a knee joint swelling, you may not want him to stand on that leg and do any or do an active passive movement by making him lie down. Because again, as we said, this is a screening test, right? You want to pick up what you don't see, obviously.
But if the lower limb is painful, the upper limb should be done. Sometimes.
Yeah, even the joint knee is affected, you try to do other things, whatever the child is able to do without significant pain. Okay, I'm not trying to skip anything at all. I'm just saying that you should be sensitized towards what you are doing.
Dr. Jayashree is there? Yeah. So anybody who's answering a check, what are the 3 things we said it differs from the adults? Anybody from the online participants can answer that? Dr. Jayashree? Dr. Nikhil, you want to answer? How does it differ from the adults? No one from the online, somebody unmute. Or next session, they will not be allowed to join. I'll take 3 names. Dr. Nikhil, Dr. Durgeshwari or Dr. Priyadarshi. Anybody wants to answer? All are sleeping, sir.
It's okay. It's good to sleep. It's no problem. We are awake, so don't worry about it.
Okay, so we will do with this patient, and I just want you all to see the patient when the patient is walking in the room.
Dr. Sikha, just 1 second. I'll adjust the camera so online audience can see. Just on a lighter note, make sure that you don't put your fingers in baby's mouth. Huh? They can bite.
Such it is your own fingers. Huh? It's not your fingers.
Correct. It has to be baby's finger for baby's health and your health as well. They don't like you, they will bite it off.
So this camera is उनको दिख रहा है वो दिख रहा है so ये हटा दो थोड़ा सा let him walk and I would like to assess when he walks आजा बेटा which is the what which is the more predominant one where he is skipping his so he is keeping his wazn on the weight on the left. So now you can understand very nice. So you can understand the right is right. Sure, sir, sure. So you can understand how it was important just to understand the stance and swing phase that he was not keeping the, though his both legs are affected here, we can see, evidently see that both the legs might be affected, but it is more keeping the weight on the left side, so right might be more affected as compared to the left leg. So here in this situation, sir already told we should not do certain maneuvers. We cannot ask him to walk on the toes and the heel. Right. Because we can evidently see there is the ankle swelling in both the ankles. So we cannot ask that. So we will start with the arms. Babu, idhar aaja. Baithoge idhar? Aaja. Okay. Come here.
Sit down. Can the online one see here?
Yes, ma'am.
You can see the patient as well?
Yes, ma'am.
They can. So you will come and do the arms at least. Beta,
चेक करेंगे क्या दर्द हुआ तो बोलना है हाथ ऐसे पूरा एकदम सीधा सीधा करना
very good. Aditya.
So when you're performing PGALs, you remember to make sure that there is no cheating. What I mean by cheating is, if my left shoulder is painful, I will, rather than doing this, I'll try to do it this way and lift it up. Okay. So that's my compensatory movement. It's not cheating, but you are supposed to pick it up. Same way, if there is a mild pain in the wrist, they will do, or they're lazy, they'll just do like this. So to make sure that you get a proper 90-degree, and when you do this also, this is not good. Try to make sure how much it goes down. You may not get 90 always. But that's the important.
अपनी हाथ सीधा करके यूं करोगे
मुट्ठी बना दे बेटा
दोनों
So, it's good to say mutti banao, but it's always good to say aise mutti banao. Right? So once you demonstrate, the important thing is when you demonstrate, one, the patient knows what you're doing, but more importantly in the exam, the examiner knows what you are asking for. So even if the patient doesn't perform, you get your marks or points for that. That means you have explained what you are looking for.
you cannot extend this hand.
So go ahead, you will understand further. Okay, then next you have done seeing this, then this.
जैसे मैं कर रही हूँ ऐसे सीधा रखते हाथ
Very good.
ऐसे ठीक 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 दोनों हाथ then अभी ऐसे करो एकदम ऐसे ऐसे करो then अभी
You have to do, you will not see the. So you ask them to do this and then metacarpo. That's the. So it's just like this. You just do it.
मैं वो तेरा मैं
हाथ ऊपर करो ऊपर फीलिंग का फीलिंग
Very good. Kobe. One thing to understand that this is not sketching. So that is it as a properly made you identify which the child even did not complain. While entering, we were just focused on the lower level. So right side, you can understand that. Anybody else? Shall I go ahead or?
Yeah, in the normal patient, when you do it, when the arms are lifted up, make sure that they are next to the ears. Okay, there's no compensation this way, or that the hands are up in front rather than directly up. Okay.
Okay.
Sir, squeezing part, can it be done once more? Squeezing part.
Can you see? Yes. So basically knuckles. You ask the hands here, it asks the job, and the knuckle part. The knuckles are the metacarpal pelvic. Yes.
Okay.
Don't need to press very hard.
It's more like doing shake hand. You're shaking doing a handshake with.
Okay, okay, sir. Okay.
इसको बहुत गर्मी लग रही है
Then next we have done seen the first toe and heel. We did not do it with this child. We did the arms of this child. No, then we'll do the legs. Okay, we complete the legs. So legs में read जो बेटा.
Ma'am, video is not available. Actually, it's not coming.
Can you see here now?
No, ma'am, it's not coming.
So there are two different video settings. So one, you can see the host. Second is also named under IAP. So try to pin that video on your screen. Then you can see both the cameras. Like you can see right now, I can see, can you see on the screen? You can see two video cameras shooting from two different angles.
You need to pin one.
Yeah.
Anybody wants to do? Do on this side. Which side would you prefer? Left side.
Why are you picking sides? Ah, good. Thank you.
So this is like this. So you press it down and you move the pattern. You can differentiate. Here the pattern is completely inside your field. You can keep this 16 pin here. You can compare the two sides and feel it. And then for the hip, see the space of the chest. That's very important. Okay. Very good. So external. We are doing the internal rotation of the. I hope the online participants can do. She's doing it very nicely. She flexes the knee and then she's taking the leg out. This gets the hip in internal rotation for the hip pathology. And if we flex and we abduct and get the knee, the hip in external rotation, that is for the SI joint. Right? Very good. So this is what. Anybody else wants to? So here it is, come here and then you can feel it. So here it is categorically like in a fluid. In this one you will feel this fluid. More like a cyst capsule. Just hold the category. So the online ones you need to be offline, huh? Just the online ones, whosoever can come, it's always good to examine the patient directly. So there are two things. One more thing, what we call is don't do the affected limb, don't move the affected limb, don't move the affected limb for the hip also, move the other limb. Yes, and then bring the leg outside. Perfect.
This is what rotation you're doing. Hip joint, yeah.
That's what is important.
The hip moves the other way, right? So when you enough.
Internal rotation is for the what pathology? And external rotation of the hip is for what pathology? SI joint. SI joint. So one more thing for SI joint that you can do is.
So when you do for SI joint, try to put the ankle on the opposite knee. Please correct me if I'm wrong. When you do for SI joint, this side is in pain. So if you can do it like that, and then when you do the when you press the knee outward, then you get stretch of the SI joint. That's one more provocative test. Opposite knee, yeah.
Anchor on the opposite knee. This is getting externally rotated. So the SI joint is very straight, then he will come here. Okay, this is one thing for the SI. This will go out. This is one thing for the hip joint. The hip joint is for the hip and the SI joint.
So which condition you do tell me the commonest condition in which you will be checking in your practice for hip internal rotation. Absolutely. Very good. Super. Transient synovitis of the hip joint.
So we are done with the legs.
And if you can't do it, as she said, in a bigger child or this, put the child in the lateral position and then give pelvic compression, then you will be able to get the SI joint pain. Okay. Why are we so much worried? Sorry. Why are we so much worried about SI joint all the time? Yeah. It's one of the joints in axial pattern of involvement. And there are very little movements that you can really check the SI joint for. So that's why these tests are important to know.
So we did gate,
and spine. So spine normally in this child is very difficult because both knees swollen and ankles swollen. So bend forward and then 3 fingers. Here, so we can at least show the swatch sign as well in the child is there.
Sure.
You guys have
About that passive movement and active movement, two different types of movement when you do the patient's lying down.
So basically, if you have PTF is a screening test, but when you have it, a knee joint of involvement, not to see, so you will have to describe in your long case a complete knee joint. So here we can see that there is a knee joint swelling. So then you will have to, even in the history, you will have to take that how it started, where it started, how it progressed, and how many months it progressed. One is that, and when you're examining also, you have to see everything. So inspection, you have to cover it, uncover it completely, and you have to see whether you can see whether the overlying skin is normal or not, where the swelling is. So the knee joint is swollen and there is a diffuse swelling of the around the knee joint that you can see. Overlying skin, we compare from both the sides, seems to be normal. It doesn't seem to be very red or something. Then we need to compare the touch. So touch me, what they say is normally as compared to the thigh, the knee should be cooler. The thigh muscles are very well perfused, so they are warmer. The knee should be cooler. But here, if you see now, if you compare from both the sides, also you all can just touch and see. This one looks more warm. It's very evidently also, and actually the feel also, you can feel it that this is warm. So it's not cooler than the thigh, neither it is cooler than the opposite knee. So that's what you will see in palpation. Okay, whether you are seeing, when you're seeing whether this is there. 3 things that we can see is one is the knee crepitus. So when you move up and down, you feel the crepitus, especially in smaller knees. Here also one. Here crepitus. In the fact, in the fluid, a kind of crepitus can be felt. Then second is when you move this, the patellar, this one needs already very fluid. Or you can move, there's a tap that can be also be done. Okay. And then like sir is mentioning, if you have passive movements can also be done and active movements like what we are doing passive movements, the child can be seen. So one is, बेटा ये पैर सीधा ऊपर उठा देना, एक ही पैर, इसको ऊपर उठा दो सीधा, ई को बेंड मत करो, इस वाले को उठा दो, तो बेंड मत करो, एंड इस वाले को उठा दो, ऊपर देखो कितना हो सकता है, नीचे लो, इसको भी उठा दो, नीचे रख लो बेटा, वेरी गुड, इसको भी नीचे लो. So one straight leg test can tell a lot of things about the knee and the hip.
So in the PGALs also now, we can check the movement of flexion extension at the knee, active as well as passive. Okay. So just wanted to say that don't miss out on doing active as well as passive movements. So you show me how you check for active movement at the knee, flexion extension. No, not leg. Don't do that leg, please. Sorry. Say na, talk to him. What is his name? Okay, good. I didn't notice you, any one of you asking. That's why I was wondering. That is against resistance, what you're doing right now. No, okay. Yeah. So what I was trying to emphasize is any joint examination when you do, you either need to fix the proximal joint or make sure that the movement is isolated at that joint. Okay. If he just lifts it like this, then there is a movement at the hip as well as at the knee.
Terminal range of movements can also be checked. When we're doing a passive, so sometimes when there's a small amount of fluid, the terminal flexion or terminal extension is affected, which can be checked. This child, of course, the right is severely affected.
Ma'am, can you please use the mic?
So when you're doing passive range of movements, you can see the terminal movements also, the terminal flexion, terminal extension, which in active the child might do a bit, but then you can assess what restriction is there in the terminal. Okay.
What is the other advantage of checking active versus passive movement? Suppose somebody is having pain only on active movement, but not on passive movement. And the other child is having active as well as passive movement. What is your interpretation? Say it now. It's not no trick question. I'll put a disclaimer. So everybody thinks I'm asking trick questions. Malingering, no, that's why you're smiling. That's why I said it's not a trick question.
So, so only on active, you can think of multiple pathologies like multiple, there can be muscular problem.
Excellent.
Excellent.
So you are
So
saying it's a
peri-articular.
peri-articular involvement versus an articular involvement. Okay, excellent.
So similarly, when the fluid here, you can see it's a diffuse swelling. When it would have been a peri-articular, for example, sir mentioned Osgood-Schlatter disease. So there would be a swelling here. Child would still limp. The mother would still complain of knee joint pain, but it would be more of a localized swelling here. Okay. Yeah. So tuberosity gas pass. But here you can see how diffuse the swelling is. It's more inside the joint. You can decipher it. And like sir mentioned, passive and both passive and active. Well, active and both passive and active. So both, if you move anything now, we'll have pain. In that one, maybe passive is not painful, active is more painful. But of course, it comes with a rider. Sometimes otherwise.
Oh, yeah, of course. These are all rules with exceptions. And so again, 2 points to repeat. One is if pain is not there on passive movement, and if there is point tenderness anywhere around, then you think about in non-articular or extra articular involvement, classically being enthesitis of various varieties.
In this patient,
So you should also know what are the points of insertion of the tendons so that you can look for enthesitis. And even from the chat can tell me if you commonly points for enthesitis. Which are the areas where tendons are commonly affected? Touch and show me. No? Touch and show. This theory is of no value. No, don't touch that leg here, please. Hurts me also. Very good. Very good. Don't press. Just touch. Don't press. You have metacarpal. Metatarsal, sorry, I said carpal, metatarsal. Okay, and commonly ahead of the metatarsals and where the insertion or to the great hallux is there.
And the fifth one lower one. So all these heads.
Correct.
Will have pain. And the fifth one, the lower part as well. So these are the commonest site. Where is your head? And the fifth one, metatarsal. So if you see the Nelson, they have made arrows. If I'm not,
Yes.
not wrong. So they made arrows on Nelson picture. Where you see for enthesitis when you think of enthesitis related arthritis. Okay, so gait, arm, leg, gone, spine. Of course, we will ask the child to bend, and then these 3 fingers for the temporomandibular joint. Vasto ka Aditya? Vasto? This way, this way. He's seeing his own photo. He's so fond of mobile. Full day mobile. Okay, mask start.
Dr. Sikha, can you show them how to, I don't know what to use. If there's a minimal effusion, how to pick it up, you know, like how we move the fluid on one side and then do the patellar tap. Oh, you did. Sorry, I missed that. Perfect. No, that's fine. Let's not, too many things to cover anyway today.
अच्छा हाँ वो हिंदी गुड वेरी गुड निकाल लिया आपने इसको करो ये 3 फिंगर डालो अपना ऐसे ऐसे डालो वेरी गुड अरे वाह बहुत खाते क्या बड़ा है very good huh? So this can also be affected in when the oral aperture oral aperture is affected it's also too much of oral ulcer sometimes that is affected huh? That is very good point. Best point. आता 2 और 2 चॉकलेट आपको चाहिए क्या?
So this which joint you are checking just now? TM joint, right?
Anything else?
Any queries? Anything you want to know about it? Anybody wants to know anything more from the audience?
बेटा 1 मिनट और 1 मिनट और मास्क निकाल लो नहीं रहने दो मास्क पहन लो तो बाय so what's all sometimes joint might have very push down this fluid from up because the suprapapillary area is the first area where the fluid will come in. So you just push down and then do the same which we so the patella or will tap the patella. Here it is very tense, so you're not feeling that kind of systemic fluid, but definitely it is there.
So normally you don't get patellar tap because there is no fluid in the knee joint, correct? Yes or no? There is fluid. There is fluid. No, there is always enough fluid. But there is not enough fluid for it to tap, right? So when there is minimal fluid, it is still spread in all the different fossa or areas of the knee. So what Dr. Sikha is saying that you push it and bring it all under one area because it's little, so little, and then you elicit the patellar tap. That way you can get it even when it's in the early stage or in a not a very significant patellar tap. Thank you. Thank you, Aditya. Ideally for PGAS, you don't need a patient. Okay, you have friends, so you can keep checking and asking each other to do it. But when you do that, no, make sure that you have an examiner standing next to you. Okay.
To discuss certain cases, and I think we have a very interactive audience here, so we'll see if they can answer certain things. Yes.
Close and open again. And it doesn't go. You can start talking. I'll open it.
Okay, so we have here a 3-year-old child who comes to you with complaints of fever for 3 days and limp for 3 days. So what are the questions that you would ask one by one? Yes. Fever for 3 days, limp for 3 days. 3 years. Which came first? Fever started first, and then within few hours, the mother noticed the child is also limping. Go ahead. One sided. So yes, it is one sided. ऐसा लगता है कि right side में नहीं चल पा रहा है properly. Right side में दुख रहा है उसको. Cold part. हाँ, 3 दिन से कैसे चालू हुआ था? 3 दिन पहले चालू हुआ था. आराम से खा पी के दिन में तो सब कुछ ठीक था, फिर उसके बाद मुझे लगा कि बहुत बुखार आ रहा है इसको, सडनली फिर 2-3 घंटे में चल भी नहीं रहा है, लेट गया है. ऑनसेट लोकेशन, आपको ऐसा कुछ लग रहा है क्या कहीं पे कुछ तकलीफ है, नी में है कि एंकल में है कि ऊपर है? हाँ, मुझे लग रहा है कि उसको नीचे एंकल में थोड़ा सा ज्यादा मतलब पैर रखने में तकलीफ हो रही है, वो बोल रहा है, वहां दुख रहा है.
Duration is 3 days. Okay. Or 48 hours, 72. Pain constant throughout the day. हाँ, पूरा दिन बहुत चिड़चिड़ हो गया है, पूरा दिन ही नॉट मतलब इरिटेबल रह रहा है, सिर्फ बुखार आता है तो दवाई दिया तो थोड़ा ठीक रहेगा, पर खाना पीना भी कम हो गया है, बहुत फीवर आ रहा है उसको। Aggravating factors throughout the day. Aggravating will not ask the mother ना? हाँ, aggravating. कुछ चीजें तो बढ़ता है, तो कभी दवाई देती हूँ तो थोड़ा ठीक होता है, बट फिर भी मुझे तो बिल्कुल टच नहीं करने दे रहा है वो जॉइंट।
So on the chat, they have asked what is the site of pain, any trauma history, painful or painless?
तो हाँ, 3-4 दिन पहले बाहर गया था तो मुझे
Dr. Mike ले लीजिए ना, please.
4 days back the child had been out and while playing मेरे हिसाब से उसको लग गया, शायद से लगा है उसको। नहीं नहीं, बेड से नहीं गिरा, हाइट से नहीं गिरा, बट मैंने उसको पूछा लगा तो लग गया उसको। हाँ, so that's what you have to decipher. Always they'll say, okay, then you'll ask the treatment history. So दवाई लेके आई थी, कुछ पैरासिटामोल का सिरप, क्रोसिन का सिरप दिया था, एंड क्रोसिन देती हूँ तो बुखार उतर जाता है, पेन भी थोड़ा बेटर होता है, बट ऐसे चल नहीं रहा है बिल्कुल भी, he is not working at all. So basically,
No, Doctor, 1 second. I think, are you all able to see the slides? Because we are able to see here, but I don't think you are able to see the slides. Just write on the chat.
can I go ahead? No?
It's not showing on that. That's why. I switched it off and on.
Slide नहीं दिख रहा है ऑनलाइन वालों को। हाँ? They have mentioned in their chat. No?
Yeah.
So basically in short में onset, progression, duration, distinction में old cards पूरा लेना है अच्छे से. So she took properly, but then you have to be, of course, when you'll be asking the mother, you'll ask
Thank you.
all the things, right? So onset was sudden, not being able to bear on the right leg. 2 days ka history I cannot describe, but the child is very irritable and fussy, like I told you. Mild relief with crocin whenever asked to stand and throughout the day. And for the mother, this pain seems to be very severe. There are certain things you should ask leading
So it
questions
is
to them.
transient synovitis of the hip joint. Commonest cause. Now you said transient synovitis of the hip. Somebody said, no, internal rotation. Yeah, so don't you think this is transient synovitis of the hip? No, with this much history only. Tell me. बाद में क्या है? They will be able to bear weight. Very good. So that's first point against transient synovitis.
The pain would be throughout the day,
Pain would be
maybe,
throughout the day.
but the child would not be very irritable or fussy, and
Not seem
fever.
severe.
Very good.
And fever, correct?
Very high grade fever, which is lasting
Absolutely.
for every 4 to 5 hours, requiring paracetamol every 4 to 5 hours. So very significant fever. Okay, good. Now the slides are not moving.
The arrow again. Let's see. You know, all these are all the deliberate attempts to frustrate online people so that you will come and attend.
No, at
attend
least
over
I think
here.
these 5 people can say when they see the demonstration on the patient, that makes a huge difference, right? And you're seeing a patient who is affected, who has arthritis, limping in your, while examining. So of course that makes a huge difference. So kudos to the Hinduja group. No? They're all from Hinduja. 3 of us. You are from? Jupiter.
Jupiter, right? Excellent.
Jupiter, just look and
Hinduja.
So the leading questions, like I was saying you, history of trauma, of course, you have to decipher significant or not significant. And then you have to ask what happens when you child to hold the child or console the child. So console is like the mother says कि जब भी उठाती हूँ तो वो उठाने भी नहीं देता है. In fact, कभी भी उसको उठाने की कोशिश की तो ज़्यादा रोता है. He just prefers to lie down on the bed in that one particular position. मसाज कोई हेल्प नहीं कर रहा है, कोई और जॉइंट में मुझे नहीं लग रहा है. हाँ, रात को भी बुखार आता है, दर्द होता है, टच हो गया तो बहुत ज्यादा दर्द होता है. सो स्लीप भी अफेक्टेड हो गई है उसकी. ओके, If we summarize, then of course you'll take the treatment history, past history, medical history, family development, and we ask the past history. So you the history comes कि हाँ past history में उसको एक 8-10 दिन पहले left thigh में एक छोटा boil हुआ था और हमने उसको थोड़ा दबाया तो पस निकला था और local ointment लगाया था वहां से. So you have a 3-year-old child complaining of high grade fever or moderate or high grade fever with limp which is involving the right leg for 2 days without any witnessed significant trauma, with a history of boil over the left thigh for 7 days back, which discharged pus. Well immunized, developmentally normal, otherwise active, doing everything normally before the onset of this illness. Yeah, so osteomyelitis.
What is toxic synovitis? Means sinister disease, non-sinister disease. It is sinister is bad, right?
Disease.
Sinister means bad. Sorry.
Okay.
So we say transient synovitis as a rule. If you're talking about transient synovitis, if we say toxic also, you're not talking about septic arthritis, right? So that is a differentiating factor. You think this is osteomyelitis?
Yes, yes.
Okay.
So what is toxic synovitis?
I don't know there is anything
Same thing,
like
I
toxic
think.
synovitis. Means
There's
some
a-
people use toxic and transient interchangeably,
Interchangeably. right.
especially if it is associated with some viral infection, etc. That's like a reactive kind of injury. But transient synovitis typically is used when you have a history of the child having had excessive physical activity the previous day. They've gone for a trampoline or gone to a party or used a slide or jumping or whatever else. And then they've landed up with an edema. So that is why these two. But what I'm trying to emphasize is when you use the word toxic, it sounds more dangerous. But toxic is generally used in line with transient synovitis as far as management is concerned.
So the online participants also feel that fever is there, this is there, monoarticular, polyarticular, single joint involvement here we are dealing with. The child has single joint. The differential is osteomyelitis of the joint, osteomyelitis of the joint and septic arthritis. Okay, fine. Durgeshwari says septic arthritis or osteomyelitis. Okay, so here this is what. So when you come with an acute history, then you have 3 very important things. Coagulopathies, trauma of course, and septic arthritis and osteomyelitis. So acute and chronic, again, the slides are not moving. We know.
It's showing your first defined limb slide.
The 3 important things when we are dealing with acute within days, by that time, I hope online ones can listen us. Okay, so within days, if it happens like 2-3 days or a couple of days, then trauma, bacterial infections, which can be osteomyelitis or septic arthritis, and coagulopathies. So young boy, if I say male child, and then has a hemarthrosis, hemophilia can be important. So these small things, gender of the child is important, the age of the child you're dealing with is important, and how significant the fever is. Fever can be there in transient synovitis, which can be a past history 3-4 weeks back also, or very mild fever, not very severe fever. And the pain would not be very severe so as to bedridden the child, not being able to console also when you carry the child. There are few simple things which will help you. So if you have a case of septic arthritis in the ward, definitely long case would be there. Okay.
What do you do to this patient? In exam, they'll ask you, what do you do for this patient?
To make this child calmer.
Oral ibugesic syrup, ibuprofen syrup, paracetamol, oral paracetamol. Okay.
Yeah, that he is already getting.
Okay, so oral ibuprofen or naproxen, what do you want to use? No, we are not looking at coagulopathy. We are looking at septic arthritis. We'll assume that. There's no problem. Coagulopathy, you don't think here because.
I give you examples.
Ah.
That if you
So if
a very small child, male child without fever, history of trauma, and then a joint swelling, then think of how gender, how the age, how the presentation helps you to reach a conclusion. That's what.
Then what?
Then we'll investigate to confirm our
So what
diagnosis.
you want to do?
Sir, if septic arthritis is suspected,
You'll send CBC.
no, I mean,
No?
we'll do a USG of the joint.
Okay.
And if osteomyelitis, I'm suspecting I'll do a MRI of the selected
So
region.
sonography, the sonologist is, you are not in Hinduja hospital, huh? I mean, or not in Nanavati or Jupiter or just local. Okay. So sorry, I'm not being funny, but MRI means you'll take the patient for MRI, give sedation. You have given ibuprofen recently, so not nil by mouth. So you will wait for how many hours before you take the patient for MRI? 6 hours.
6 hours.
Very good. Your new Nelson unfortunately omits one line which the older version of Nelson is to write. Septic arthritis is a orthopedic emergency.
Okay.
Okay. Emergency. You don't have hours. You have minutes. Okay. What happens if you wait for 6 hours and do the MRI? The femoral head will necrose. No, femoral head will necrose. Simple as that. So even, I'm not saying that we should talk in the exam like that. Probably you say as early as possible, we will, no, you can't see anything. So you will say that you will try to do urgent diagnostic investigation. Otherwise, you will take the patient up under sedation for at least a diagnostic tap. And if pus, then go for exploration at the earliest. Just show urgency in your management. Don't worry about the CBC or blood culture or even for your CT, MRI. Ultrasound, I would still accept, or even MRI if it's available and you're going to do it quickly. Then otherwise, you're suspecting septic arthritis, needle aspiration
I
is
said that if
acceptable.
I am suspecting arthritis, septic arthritis, then USG is the investigation of choice. And
correct. That's what I'm saying. If available. No.
Okay.
See, what I'm saying is we assume because we are sitting in centers where we'll have hopefully a sonologist who is available. You are in a nursing home, your sonologist or the sonography center is 2 hours away. What I'm trying to say is there is no point in wasting time. I always give example of torsion testis with this. Okay, so treat it the same way. और वो full screen करेगा तभी रहेगा कि नहीं देख लो.
Let's not do 15 now.
It's there, but it won't move. You move it there, it won't move here. It's moving here. Perfect. Let's run with this much.
I think we omitted these 2 slides where for this has to be individualized.
If it's coagulopathy and you put in a needle, what will happen? Since you mentioned coagulopathy, I'm just saying. Nothing will happen. He was already bleeding, no? So one small needle you put inside and take it out, nothing will happen. You'll get blood and you know it's there. But you can do a PT-PDT if the setting is such. And classically, this applies for hip septic arthritis, not for many other things. All yours.
Acute conditions.
I will not interrupt now because I don't think we have much time. We have 20 minutes more to
I think
finish.
we're done.
Okay, fine. That's good.
There's another case we can run through that. So bacterial trauma and coagulopathies is what in the acute ones, these are subacute kind of situation, post-viral, like post-COVID we see, or neoplasias or a start of JI, which can happen. And these are the chronic infections, tuberculosis and all, if there is a chronic history of chronicity. Okay, examination, you find the child is febrile, crying, tachycardia, tachypnea. You see the anthropometry. Position of the limbs would be, if there is a hip involvement, the position of the limb would be, we have already written. And right, so right leg is flexed and externally rotated. We start with the normal leg and we also see with the scar because there was a boil. So we see whether there was any scar or not. Left knee, leg, knee, ankle, hip are normal. Right ankle overlying the skin is red and inflamed, swollen, gentle touch also. And the child winces his pain even if you try to touch it. Okay, so this is what we have. So left side is okay. So other systems you examine and then finally you summarize and give differentials. So in the differential, the first and the foremost thing is osteomyelitis with septic arthritis. So osteomyelitis is one thing. Just to add it, septic arthritis is usually there, small amount of fluid, but if you palpate the bone from up down, for the shin up down, And in the bony part, if you feel the child starts paining, then there is more osteomyelitis. You understand? Right? The joint, of course, affected hoga, wo bone pe hi rona start karega bachcha. So that is more of osteomyelitis. So we'll summarize and give the differential. So can you give another differential? Sometimes the examiners, you tell one more. What else will you consider?
You have to think so hard. Say, sir, I can't think of anything, or madam, I can't think of anything. Nobody can put a gun on you and say, if it's thalassemia who is taking transfusions from 1 year of life, there is no differential. It is thalassemia major, period.
For septic, it says first, second, third differentials are septic arthritis or osteomyelitis only. Yeah. If the fever would have not been so significant, if the pain would not have been more significant, then of course transient synovitis. If there was a hip involvement, there's an ankle involvement. Another possibility, if I would have said 8 years old boy hai, yeah, for that 3 years or 5 years old boy, reactive arthritis can be a possibility. Again, no such fever, no such pain in reactive arthritis.
But here I thought you would say acute rheumatic fever. Pain on touch, ankle joint involvement, presence of fever. What more you want?
Yes.
Cardiac examination is normal. Now, what you want in cardiac examination? Joints, the valves are not going to get involved in your first episode of ERF. Carditis may not be evident. It's just arthritis at this point in time.
Only one point that would go against here would be.
No, ankle can be.
Ankle
There's no
can
rule.
be.
Ankle cannot be involved. Sorry.
So then he's taking NSAIDs and the relief is not that much. Again, that is not sacrosanct for acute rheumatic
that's
fever.
an important point, right?
Uh,
Big joint. Ankle is a big joint.
So that can happen, of course. And even a lot of times, rheumatic fever might not completely get relieved with NSAIDs. Another possibility is reactive post-streptococcal reactive arthritis is another thing which can happen. But post-streptococcal usually do not have so much of fever in them.
How do you differentiate reactive arthritis from ARF arthritis, rheumatic fever arthritis? Common questions in exam. Migratory is when it, sorry, I'm just being a tough examiner, trying to be a tough examiner. Migratory is when it will migrate, no? First day, you migrate after a problem, right?
If I
Right now it's monoarthritis. So how will
Okay.
you say it's migratory? It's not migratory.
So from history, if we take, so reactive arthritis has a infection preceding, I mean, history of fever, usually a URI or a
ARF also has
gastrointestinal
history of
infection.
fever, no? Streptococcal throat infection.
Yeah, so
Sore throat.
that's what I'm saying, sir.
So you're saying in favor of rheumatic and not in reactive.
No, I am saying usually in reactive post-streptococcal reactive arthritis or any reactive arthritis, the fever is preceding, then there is a asymptomatic phase, and then there is onset of the arthritis.
Correct.
Whereas in acute rheumatic fever, the onset is either with arthritis or fever, and the other symptom which is left, that will come in some hours or maybe 1 day or 2 days.
Okay, that last line is not accepted, but first the other half is accepted. The symptoms may not come. No, arthritis can be there for
Yeah,
a long time
only
before you
arthritis.
get any other symptoms.
Yes.
But also what I was looking at is what Dr. Sikha said. Response to analgesia is very good in rheumatic fever. The pain is much more. Even touching the joint, or as they say, move a cloth over it, also you get pain. That is significant. And reactive arthritis, rest of the things you said, right, about it.
And one more thing, migratory is no longer included in the 2015 updates of the acute rheumatic fever. So you cannot always harp on my being it migratory, especially because we fall in moderate to high risk category group endemics.
This is my
Reactive is
favorite
also acute.
dialogue.
Acute
Okay, I have to
rheumatic
say
fever is
this.
also acute.
You may not have seen that Saas Bhi Kabhi Bahu Thi wala story, right? So everything chronic is acute at some point in time. So right now we are acute, yeah. So that is how it is. That's what goes for migratory also. No? For migratory, all polyarticular can be monoarticular sometime.
Okay, so here we have the differentials, and if anything questions, if there is any, we can take, or we can just go ahead with another case. Yeah, so here we have a 3-year-old child limping gait for last 2 months.
Rapid fire now. Quickly answer. Pick up the mic, one person, and shoot.
Yeah, she has it. Yeah, next one. She already took the
What
old
is,
cards.
hot potato. Start.
So limping for 2 months, 3 years old child, limping it for 3 months or 2 months. What will you ask?
So first the thing is that before 2 months of the child absolutely normal, any complaint before 2 months.
नहीं, कोई complaint नहीं था, बिल्कुल normal.
Then the second question is along with limping, does he have any other complaint?
नहीं, और कोई
Is he complaining of pain?
या हाँ, दर्द होता है. हाँ, so
Is he complaining or
left, हाँ.
pointing towards any side or any
हाँ,
location?
लेफ्ट नहीं. सो फर्स्ट थिंग ऑनसेट, हाँ, धीरे धीरे. आपने कब नोटिस किया? मतलब ऐसे ही हम देख रहे थे, वो काफी दिन से ठीक ही खेला था, फिर अचानक से कुछ दिन हमें लगा कि नहीं, ठीक नहीं खेल रहा है और एक पैर को सीधा नहीं रख पा रहा है. तो हमने लगा कि ऐसी ही कुछ चोट लग गई होगी, और उसके बाद अभी हमने देखा कि अरे वो तो प्रॉपरली वो चल ही नहीं पा रहा है उस पे.
Progress हुआ है, आपको ऐसा लग रहा है कि बढ़ रहा है रोग?
हाँ, हमें ऐसा लग रहा है बढ़ रहा है. पहले तो 10-15 दिन हमने लगा कि चोट लग गई है, ठीक हो जाएगा ऐसे ही, तो लेकिन वो ठीक हुआ नहीं, और ऐसा लग रहा है कि एक नी जॉइंट में, नी के ऊपर उसको स्वेलिंग भी आ रही है.
Swelling भी लग रहा है. और पूरा दिन रहता है कि सुबह ज्यादा कंप्लेन करता है कि शाम को
नहीं,
ज्यादा?
सुबह उठता है तो पैर ही नीचे नहीं रखता है.
सुबह उठता है
हाँ, पैर नीचे नहीं रखता है, और लेकिन उसके बाद जैसे दिन उजड़ता है ना, तो फिर थोड़ा बेटर हो जाता है. लेकिन फिर भी रात को भी रहता है, शाम को भी पेन रहता है, बट बहुत ज्यादा नहीं है. सुबह तो बहुत ज्यादा तकलीफ होती है.
मेल और फीमेल?
लड़का है, बच्ची है, फिर बच्चा?
मेल चाइल्ड.
और कुछ ऐसा है कि आपको लगा कोई दवाई दी है आपने, सो घर में कोई ट्रीटमेंट?
हाँ, सो हमने लोकल डॉक्टर को दिखाया था, उन्होंने कुछ पेन का दिया था, बोला कैल्शियम की भी कमी है, तो कैल्शियम का दवाई दिया था उसको, और कुछ एक
उससे आपको
दवाई.
कोई फायदा लग रहा है?
नहीं, उससे कोई भी फायदा नहीं लगा हमें, वो तो बढ़ते ही जा रहा है उसका प्रॉब्लम अभी तो.
चोट वगैरह कुछ लगी थी? कुछ
चोट लगी थी, हाँ, वो जो बोल रहा था
किस
मुझे
तरह
कि
की चोट लगी?
2 महीने पहले जब उसको लगी थी, तो उसने बोला था कि वो शायद साइकिल खेलने गया था, तो बोल रहा था मम्मी शायद लगी है चोट.
पर ट्रॉमेटिक एंड नॉट कंसीडर फॉर 2 मंथ्स का मतलब है?
You can still consider whether it's significant or not. उसको you can, another thing you can ask following a cycle trauma is कि स्किन पे लगा था कि कुछ, स्किन पे कितनी
वगैरह
बड़ी
आया था,
चोट आई.
कुछ
नहीं,
उसको
खून
लगा?
वगैरह कुछ नहीं आया, मुझे तो देखने में भी कुछ नहीं दिखा था, बट वो बोल रहा था चोट लगी है. हाँ. So go ahead. So that is what we ask: onset, progression, duration, all cards. Onset, location, duration, character, aggravating and relieving factor, timing, of course, and severity we have asked. So it's a gradual, walks with a limp, keeping the right knee bent with swelling. 2 months just around the New Year Eve that the child mother feels that later also right ankle also started getting involved, and cannot describe child is otherwise happy. बाकी सब दिन टाइम पे खेलता रहता है, ऐसा अपना भूल जाता है बहुत बार, बट पैर सीधा नहीं करता है फिर भी. Over the day, child is better, sometimes given medications and more in the morning. Seems to increase now, cannot straighten his legs, her legs. I think into the female child. So I've already mentioned the right ankle में भी अभी पिछले I think 1 महीने से पहले तो सिर्फ नी में था, अभी राइट एंकल में भी उसको स्वेलिंग आ रही है. Okay, so that's what now for the swelling. You, मतलब sometimes you have to have a history of the swelling also कि कितनी छोटी थी, कैसे बड़ी हो रही है, swelling का history जो हो गया ना, because you have a limp now, you have a knee joint swelling का history. So gradual, small initially, gradually increasing. Diurnal variation है क्या swelling में, सुबह बढ़ जाती है, रात को कम हो जाती है, या ऐसा कुछ. So
नोटिस किया है आपने?
नहीं, ऐसा मुझे तो नहीं लगा, बट मुझे गर्म लगता है वो joint. So usually mother usually complains कि वो बहुत warm है, because she will always touch the child and to feel it, and then the child will, mother will say. Okay, so this is what, again the same negative histories that you have to ask. कि trauma आपने पूछा, उठाने पे उसको अच्छा लगता है क्या? So in this child usually the mother will say कि हाँ भाई, उसको गोदी, उसको लगता है गोदी लेके चलेंगे तो अच्छा रहेगा उसको, खुद से चलने को ही नहीं बोलता है वो. मसाज मैंने किया है उसको, कभी कभी बोलता है अच्छा है, लेकिन ऐसे कुछ स्वेलिंग कम नहीं हुई या पैर सीधा नहीं हुआ उसका मसाज करने से. एंड स्लीप नहीं, रात को सो जाता है, एक बार सुला दिया तो सो जाता है. हाँ, सुबह उठने के बाद या रात को कभी नींद खुल गई सुशु के लिए तो बहुत तकलीफ होती है उसको. The treatment, past, medical, family, of course you will ask. Family history में supposedly if it's an 8-year-old boy, and then they might complain कि पापा को भी ड्राइवर है, बैक में तो बहुत ही पेन रहता है उनको, बहुत बार मेडिसिन खाते रहते हैं वो अपने आप से लेकर के, फार्मेसी से ला करके.
But his job profession is.
So that is also one thing, and how much is that are also deciphered. Okay, so here you have.
So if you get any corroborative history or any other small history like this, father having similar things, don't leave it by asking 2-3 questions. Take it like this is your primary case. Which joints are affected for the father? Since when it is affected? Are there any swelling? Because for all you know, he may be having some shoulder pain, something somewhere else. Yeah, what you are looking at angst or something like that with some other genetic component, then you must take proper history.
कुछ weight loss हुआ है इन दिनों उसका?
हाँ, वजन कम हो गया है पिछले 2, हाँ, so weight loss का history, sleep का history, appetite का history becomes important. So usually you will have, because 2 months का history chronicity है, so there might be of some weight loss. So खाना नहीं खा रहा है बराबर से, ऐसे खा लेता है बीच बीच में बट कभी नहीं खाता है, and वजन कम हो गया है इसका over the time, 2 महीने में. So 3 years female. So I think I included a female child with gradual onset painful limp of the right leg for 2 months, gradually increasing swelling of the right knee, followed by the right ankle, without any systemic features, without any witnessed significant trauma. So you'll have to summarize in a developmentally normal child, well immunized, developmentally normal.
3-year-old girl with gradually onset painful limp.
That I've already summarized here. That's what, huh? So basically, we also include the developmentally normal child, well immunized child with no significant past and family history. Okay, so same thing again, the acute and chronic. So of course, here you would not go by the acute things, you will go by the chronic things. So chronic things, infections becomes one of the priorities. So since tuberculosis is a here, we are giving as a differential. So you have to take that pertaining history. Khasi hai kya, kuch aur contact hai kya. So all these should come in your history when you are discussing this thing. So contact nahi hai, khasi nahi hai. Pehle 2 mahine pehle bilkul normal tha. Plus another thing that happened here was 2 joints got involved, knee also and ankle also.
It can't be TB, right? Because 2 joints got involved. Less likely, correct.
So vital stable anthropometry, of course, we will take and usually need a knee in flex position.
What were you thinking on history? Sorry, huh? Quickly.
Sure, please go ahead.
What were you thinking on history? Because when we went to examination, right? So give us some differentials. Very good. Okay. Inflammatory. So SOGI? 2 months, no? Abhi और कितना time लेना है?
2 months we should develop more joints.
So it's not SOGI.
So they should have fever. SOGI ka first criteria is fever, no?
Correct.
Cotorian fever, yeah.
Then
Oligoarticular GI is my first differential.
okay.
Then second differential will be a chronic infection like TB or Lyme's disease, but the possibility
Lyme's. Passport check करना पड़ेगा.
Lyme's is very.
Though we are seeing Lyme's now, Lyme is being reported in some part, but see Brucella, Lyme, all those now you must have a sort of a PUO along with that. There can be exceptions, but don't put those conditions as otherwise oligo AGI is fine.
TB a little lower side because
Yeah.
fever is not.
Okay, so let's not beat around the bush. We'll focus on this JIA business. So whenever you think about JIA, make sure that you ask about rash and eye changes.
Eye changes,
That's all I
very
want
important.
to say. Okay.
What will you ask in the eye changes?
Discharge.
Okay.
pain, redness, and
Discharge. What color discharge?
Pain, redness.
If you wake up the
and-
examiner, then you are in trouble. Okay.
family history.
So loss of vision may. Here is a blackboard, decrease in vision.
Why
Right?
is there decrease in vision in JIA?
Uveitis. What kind of uveitis they have?
Uveitis is a complaint of loss of vision. What is the complaint from the patient?
Redness and pain.
Redness and pain, correct? And loss of vision, yes, but pain and redness would be much more. Please correct me if I'm
So
wrong. Okay?
normally. na
Chronic
the-
uveitis, I'm not talking about. I'm talking about acute presentation, which you get. with
So
JIA.
maximum uveitis will be a chronic uveitis, and where decrease of vision or blackboard seeing becomes more important, except the era variety will have redness of the eye.
Right.
Acute symptomatic uveitis. He did say about pain and redness first. Okay, so this is what goes. So we evaluate again the same thing. We see the history, vitals, again, knee, keeping the knee in flex position. The right leg is flexed, externally rotated. We start with the P-gals. We've already done it. Left leg and hip are normal. So overlying skin is usually normal, swollen. So this is the typical, the child which you saw na, skin will be normal, sometimes very rarely red. Matlab red hoga to tumko infection zyada sochna hai, and then you will have other signs of inflammation like the child, this is warm, swollen, that you will feel, and restriction in the range of movement you can feel. Matlab so much that you don't even feel like examining that knee which is affected. So evident swelling you have here. Okay. Of course, other systems you will examine. Pallor is usually present, may be present, may not be, but then in chronic diseases, the pallor and anthropometry gets affected. So in chronic diseases, sometimes weight also, and then if it's too chronic, the height also is not normal. So that gets affected. Summarize and differentials. I think that is it, no? So this is for the.
So for that case, oligoarthritis, oligo-GI and other differentials.
I would not put malignancy because on history, at least I would not put malignancy. 2 months of history with nothing more than just weight loss. So I would not put that as an
Malignancy, I don't know. Reactive,
because
you
see,
can
there is no
still say.
fever. There are no other issues. So it's very difficult. So what are you looking at? What type of pattern it is that you try to understand in GIA? So what are you looking at? Type of joint involvement. You have 2 joints involvement. They are large joints, non-axial involvement, additive pattern, right? Deforming, non-deforming, we will see later on. And no fever. So sometimes, like us general pediatricians, we would think about ruling out certain things. So if there is fever, I would rule out poly-GIA, oligo-GIA. Correct? If there is extreme pain, I would think about septic arthritis. Then I will think about rheumatic arthritis, simply because septic arthritis is urgent to treat. I'm talking about monoarticular. Correct? So this one, I would think of it as oligo-GIA. Doctor will say if there is anything more. Anything else other than oligo-GIA for
No,
that
sir,
patient?
I think,
No.
yeah,
I think that's
first
fine.
thing is that only.
But as doctor said, reactive can still be in the picture because almost everybody will have some history of some fever somewhere.
But again, thoda sa shorten history hota in reactive, here it's too prolonged. So
Correct.
first is of course oligo. If you're really prompted to tell something else, you can consider, but then you have to say that these are points negative against reactive arthritis. So again, my first possibility is oligo only.
So in
the-
exam, no, suppose like Dr. Sikha said, somebody puts a gun on your head and says that, no, what is your, you don't have anything else. You don't have anything. You can say, okay, I might consider reactive. Is there signal to say it's 5 o'clock? They are not responsible for this. Okay, anyway, we have 2 more minutes, so we can keep them quiet and thank everybody. What was the answering? Yeah. Somebody puts a gun on your head, no? You say it oligo-GIA, but I may consider reactive arthritis, and before you finish reactive arthritis, you say, but these things don't fit.
Yes, that is the best thing when you're giving differentials.
Basically, that's what they also want to know. Why are you not thinking of something else?
Yeah.
Thank you.
We'll finish it off.
I'm done. You want
Okay,
to
so there
carry
was
on?
nothing
Fine.
else. This is a short case, like we are saying transient synovitis. Now there will be mild fever, left side pain on examination, left hip movements, painful on act. So basically this one. So here are the acute onset pain following significant
Why not we give
trauma.
them, sorry, why not we give them the 2 or 3 cases as homework?
Yeah, that would be better.
And they
So
can
there's
write
nothing,
an
sir, it's done.
answer. Okay. So that's a balloon. Thank you. So we enjoyed taking a physical class, and I would push everybody to take part, more and more people. I don't want all 135 of you to come here because this guy will run out of coffee, I'm sure. So he will not want 135 people to come in here, but as many of you as you can come in, it will be more interactive and good for all of you. And we really enjoyed. Thank you all who are present
Yes,
here.
thank
and
you all.
also
We have
those who are
chocolates, extra chocolates for who all. I got chocolates. I hope that they will interact.